Dear ESTS members and webinar attendees, my name is Schmitt Opitz. I'm your moderator for today. This webinar is the third one of our fourth season of the ESTS educational webinars. The subject for today is oligometastatic lung cancer. And since oligometastatic lung cancer treatment needs a multidisciplinary approach, I'm very proud to introduce you to our expert panel for today. Professor Isabel Schmitt Opitz is well known by our society as our current treasurer and president-elect. She's also the chief of a thoracic department in Zurich, in Switzerland, and the head of the Lung and Thoracic Oncology Center in Zurich. One of her clinical and research focuses is advanced oncological resections and oligometastatic disease as well. Welcome, Professor Schmitt Opitz. Professor Dirk de Ruysscher is a radiation oncologist in Maastricht in the Netherlands. He's a full professor of respiratory oncology in Maastricht and full professor of radiation oncology at the University of Leuven in Belgium. His clinical and research focus goes to lung cancer treatment and proton therapy. He has an incredible track record in lung cancer research, so also welcome to you, Professor de Ruysscher. And last but not least, Professor Rudolf Huber, chief of the Thoracic Oncology Center in Munich, Germany, and Professor of Respiratory Oncology at the Ludwig Maximilians University of Munich. Also, he has done a lot of research on thoracic oncology and especially in lung cancer. Welcome to you as well, Professor Huber. As usual, we will ask your interactivity. So be ready to answer some poll questions and please ask as many questions to the experts as you want. I will give the word to Professor Schmitt Opitz to start with the first case.
Hello, everybody. Also from my end here in Zurich, it's my pleasure to start this interesting webinar about oligometastatic non-small cell lung cancer with a case, and we prepared together with Dirk de Ruysscher some slides and cases for you, and I will go straight into the first case. So these are my and Dr. de Ruysscher's disclosures. The case we would like to discuss with you is a 65-year-old lady who has a history of 70 pack years smoking, a very good performance status, but where the CT scan revealed, besides an emphysema, 2 lesions in the right upper lobe and a very big lesion in the left upper lobe, left lower lobe. And the subsequent diagnostic procedure as a bronchoscopy with a biopsy from the left lower lobe revealed a TTF1 positive adenocarcinoma without any mutations, negative for PD-L1, and KRAS P12C mutation. Subsequently, the further staging was completed with a PET-CT scan performed, and you can see here on this overall picture that the lesion in the left lower lobe was highly FDG avid with an SUV max of 23.6, and also the 2 lesions in the right upper lobe were highly FDG avid. We performed a brain MRI with no evidence of intracranial disease, so that the clinical staging can be summarized as a stage 4A with pulmonary metastasis. This is here also a video from the PET-CT scan, again, where you can see the highly avid FDG positive lesions. So this is the first question for the audience today, and I can see that we have quite some people online. I hope we have a good feedback, and the following treatment options are available, and we would like to ask you to vote which would be your favorite option. Number 1 is surgery on the left lower lobe, an adjuvant systemic treatment, and a follow-up of the lesions in the right upper lobe to consider radiotherapy subsequently. Next option is systemic chemotherapy, followed by LAT, local ablative therapy, being surgery of the left lower lobe and radiotherapy of the right upper lobe lesions. Third option, systemic chemotherapy, followed by LAT, surgery of the left lower lobe, sequentially of the right upper lobe as well, surgery. Next option, systemic immunochemotherapy followed by LAT, surgery of the left lower lobe and or radiotherapy of the right upper lobe lesions. and the last two being systemic treatment only, either chemo alone or immunochemotherapy. Lieven, I give you the word for the results, maybe.
Okay, so for the people who don't know this system yet, in the right sidebar you have the polls system. So you see questions and polls. You go to the polls, and there you can see case 1, what will be your treatment suggestion, and then you have the same questions there. You can vote on that. I see we have more than 100 people, 150 people, sorry, watching this webinar right now. So I expect a lot more votes. It's anonymous. You can just vote whatever you like, and then we will see the results. So I give you, let's say, a half more minute to make your choices, and then we can see what comes out of the choices of the audience. Please, for the people who still want to vote, make your choice right now. I see the votes coming in. That's very good. So maybe I can already tell you that no one is choosing for systemic chemotherapy alone. 4% is choosing systemic immunotherapy, so almost no one. And then it goes between the more multimodal treatments. 12% is choosing systemic immunotherapy followed by local ablative therapy. So that was the 4th choice. And then it's quite close call between the first 3, actually. 25% choosing the 3rd option, also 26% the 2nd option, and 33% is choosing for the first option. So this one, let's say, wins in the votes, but it's a very close call with the 2nd and the 3rd option. So you see the audience is quite divided between the first 3 options.
I think we can leave it with this, Lieven. What do you think?
Yes, it's an interesting idea. I think the first 3 options, and I don't know if you want to comment already on this, or you come back on this later.
Maybe we can come back on this later. Maybe we should have said that there's most probably no wrong answer in the current situation, and that it's maybe to be expected that here most probably surgeons are online, so don't be disappointed that they all choose surgery as local ablative therapy. But I mean, most importantly, I should mention that interdisciplinary discussion is needed for the correct therapy allocation, and this is the solution that came out of our tumor board. This is systemic therapy and local ablative therapy of the right upper lobe up front, which is part of a study protocol that we follow here in Zurich. I will come back to that in a minute. And it's a systemic therapy with 4 cycles of carboplatin and paclitaxel, followed by a PD-L1 monoclonal antibody durvalumab, and SBRT to the right upper lobe lesions, a total of 48 gray. And thereafter, a restaging was performed with PET-CT scan and brain MRI, still no evidence of intracranial metastasis. And we can see very nicely here that both lesions showed a very good response. I have even a little bit more detailed picture for you, where you can see the target lesion, the left lower lobe, really nicely responded to the systemic therapy, and the same to the right upper lobe lesions, which were non-target lesions or considered as non-target lesions treated with the SBRT, also showing a reduction in the tumor size. So I skipped the pulmonary function test because this was in the wrong sequence. The patient was assessed for further local ablative therapy of the primary tumor, and the functional assessment showed that the lobectomy would be possible. However, we were a little bit intrigued by this very close relationship to the descending aorta, where in the mediastinal window, you couldn't really see a plane between the descending aorta and the tumor. And this is why we implanted, together with our colleagues from vascular surgery, 1 day pre-op an endovascular device, just to be on the safe side if we have to take away the adventitia of the descending aorta. And the following day, we performed a minimal invasive left lower lobe lobectomy with mediastinal lymphadenectomy. And the final pathological staging is here depicted. It was an YPT1A and lymph node negative finally. And so it was actually in the end a UICC stage 1A1. Thereafter, we continued with systemic development therapy, which is also part of the treatment protocol, which I would quickly like to share with you here. It's the ETOP-CHEST trial, where synchronous oligometastatic non-small cell lung cancer is treated with this upfront immunochemotherapy and SBRT to all oligometastatic sites. And after restaging, if non-progressive disease, the definitive treatment of the primary tumor is surgery, or if not resectable, radiotherapy, and to be followed by 4 weeks of after 4 weeks of continuation with development for up to 1 year, with a primary objective, a primary endpoint of PFS at 12 months, and most probably a trial which will be ready with the accrual the upcoming year. So this patient was treated within the trial and within a protocol, but I think the answers from our audience here are not completely wrong, and I think that's a good time point maybe even to start a discussion here about the other alternatives that were highly ranked here by our audience.
Indeed, I think if you stop your screen sharing, then we can, the audience can see us all, and then you can also have a look at the questions that come in. There's already 2 questions about the aorta, if the tumor was involving the aorta or not during the operation.
Yeah, thank you very much for this good question. It was finally not, so it would not have been necessary. And we found a good plane, so it was easily, I mean, it was nicely dissectable from the descending aorta. So we could say maybe 1 procedure too much. It's the same question. Abel also asked this question. So from the technical perspective, we could easily dissect it at this location.
The problem is, of course, when you have to do it in the other way, and it's an urgent procedure, then...
I fully agree. So we really have, maybe because it seems to be a question that is highly demanded, we have really seen exactly the other ways, the other situation, the other way around, as you are mentioning, Lieven. And as after being in a stupid situation once, we decided if we have a suspicion and cannot really see a clear plane on the CT scan, contrast-enhanced CT scan, we will we do this, and we have very good experience with this, I have to say.
It's a safe solution, I think. If people have any other questions, so you had already tried the pulse bar, you can go to the questions bar, you can ask any question on this case. And maybe I ask in the meanwhile to the other panelists if they can comment on the 3 choices our audience made to handle this case. Professor de Ruysscher.
Well, actually, first of all, we also include patients in the CHEST trial, and I think that is a very important take-home message, as we will come back to it later. That is, there's a lot of uncertainties how we treat those patients in the best way, and we can only move forward to enter patients in very well-designed prospective studies. So that's why we also include in the CHEST trial. Coming back to the case, I think that what is important to stress that oligometastatic disease is really oligometastatic, in the sense that metastatic disease is really predominant. So that's why I think whatever you do, there should be the best available systemic treatment somewhere in the treatment. And of course, we'll come back to that later. The induction treatment is actually as a way to avoid overtreatment or local overtreatment in patients who will not have a good systemic response. But for the rest, of course, there's a lot of uncertainty. So I think there's a lot to be said for all options which Lieven showed us. And then lastly, what I would make as a comment as a radiation oncologist, I also think that you should know that we can irradiate those lesions like Isabel mentioned, but in general, it's not feasible because of, again, the damage to the aorta with so-called stereotactic techniques. That has nothing to do with stereotaxy itself, but the high doses per fraction. So that is also something you should take into account. What is the local expertise? Is it feasible to give radical radiation? Yes, but not by stereotactic means. And that should be discussed multidisciplinary in order to come to the best solution for a particular patient.
Any comments, Professor Huber?
Yeah, I think it's rather clear that we need both a systemic therapy and a local therapy. And as we try to get the best local therapy, we should also try to get the best systemic therapy. And at the moment, it would be immunochemotherapy in this case.
Okay. I see another question coming up about the T3 tumor and the VATS lobectomy in a T3 tumor. Can you comment on this, Professor Opitz?
Yeah, I mean, obviously, like all of us try to do minimal invasive over open resections in any case. And I have to say, in the meantime, being VATS or robotic, anatomical resections, even after induction treatment, it's still a challenge, but it's possible. I cannot tell you the precise number, I have to say. I can say that overall, our percentage of minimal invasive anatomical resection for lung cancer over all stages is 80%, or 75, something between 75 and 80%.
Okay. Maybe we can comment a little bit more then on oligometastatic disease after this case. I think you had some.
Yeah, there's still one other question. Sorry, Lieven, but somebody asked about what is preferable if you have brain or adrenal metastasis, which should be operated first. Maybe I can start, and my colleagues can comment as well. I think normally the brain metastasis is eventually the one that is, from a symptom perspective, the one that seems to be more urgent. But also obviously depends on the size and location of the tumor. If you have a very big adrenal metastasis, this is can also be the first priority. It depends on location and size, I think.
I agree with Isabel. Indeed, in general, the first thing to do is to address brain metastasis and then the rest. But that's in general. Of course, there are individual variabilities possible there.
Yeah, usually adrenal metastases are not that symptomatic. There are exceptions with large masses, but usually they are not that urgent.
Okay, then I would proceed with the slides, Lieven, okay?
Yeah.
So maybe a few general comments. Oh God, something is talking. A definition about oligometastatic disease is over the different societies defined as little as 3 or up to 5 metastases. It's quite different between the different definitions, and there cannot be only differences in the number of the metastases, but also in the setting. It can be either a synchronous or metachronous setting, and it's also a question if it is, for example, genuine oligometastatic, as it is nicely summarized in this EORTC group publication, or if it is an induced oligometastatic disease after upfront therapy. So I think this makes the situation even more difficult because from the evidence that we have so far, you have different settings, and you will see this later also in a few slides that Professor de Ruysscher prepared. In current guidelines, we have to say that in the NCCN guidelines, local ablative therapy, but also in the ESMO guidelines, it is recommended that local ablative therapy can be considered for patients who are responding to systemic therapy. But it's very important that in the case, for example, for surgery, but also for radiotherapy, that the selection of the patient is carefully performed. Here you have the results of a multi-center trial cohorts analysis that we did in Switzerland, where we have 5-year survival rates of up to 83% if patients are younger and PN0. And you can see that not only the age, but also the mediastinal lymph node involvement, as mentioned before, are very important, but also the location of the metastasis. And here we know that the bone metastasis has a very bad prognosis in comparison to the other metastases. There are, besides the chest trial, numerous other ongoing immunotherapy trial as induction for in oligometastatic disease. I have made here a summary in a few slides. Please don't read them all. It's just to give you an idea how many trials are currently ongoing here. Sorry, Dirk, I think we have to skip. Sorry, Dirk, you wanted to take over here. I don't know what is this from.
Yeah, well, maybe then you can go back. I think a few slides. I think you are too fast.
Yeah, but the problem is here is some talking involved. Can you hear this?
No.
Good.
Here it's really quiet.
Good. And go ahead.
Okay, so thank you. So I should also emphasize that from the evidence point of view, the majority of the studies we can rely on is based on retrospective series, which are I would say always biased, of course. And then you have some prospective studies and only these two randomized studies in patients with synchronous oligometastatic disease. The one on your left hand side is from Iyengar, the other one on the right side is from Gomez. But if you look at the number of patients, then you have in the Iyengar study in total something like 30 patients, and in the Gomez study something like 40 patients. And the reason is actually, first of all, it's very difficult to do these studies, but also because if you look at the PFS, the primary endpoint, then the PFS is really longer when you give the patients a radical local treatment after induction treatment. And that's why in both cases, both study groups, they had to stop the trial early because they were not allowed to enter patients anymore in the study because of the planned interim analysis and the futility. So we should also acknowledge that it's small groups, but on the other hand, they really wanted to have more patients in the study, but they were not allowed to do that. Second, very important, in these two trials, the patients first received a systemic treatment. And only when they had a nice response on the systemic treatment, then they were treated locally with an aggressive treatment. In the case of Iyengar, it was only with SBRT. In the case of Gomez, it was mostly radiation, but not only. And that is really important because it doesn't matter basically how you treat those patients locally, as long as you aim to obtain the best local strategy, that's to say, obtain local control, and at the same time with the least possible side effects. And so that means in some patients, like in the Gomez trial, it was allowed to give, for instance, SBRT for the local lung treatment and a radical resection for an adrenal metastasis, just to give you an example. Lastly, in these two trials, that was old chemotherapy, and there's hardly any patients also in the GOMEZ trial who received a TKI. So that's also to keep in mind. We don't have, as far as I know, really good data on the best available systemic treatments of nowadays. But that's, of course, something we have to deal with, and that's why it's also so important to have patients in prospective clinical studies. And also, I should stress that we don't know exactly which patient went into those trials. So we don't know whether some of those patients started with 10 metastases, had a very favorable response, and then went on with a radical treatment for 2 metastases, or whether there were only patients with a few metastases in the beginning. So there's a lot of uncertainty as well in those trials, which were set up, of course, in order to make them feasible. Next slide, please. And so what can be achieved? So we have first the INGAR study, then the PALMA study, and then the GOMEZ study. Let's first look at the ones which are indicated in blue. INGAR had no data on overall survival, but the PFS was much better when you add the radical local treatment to chemotherapy induction. In the GOMEZ study, you have a similar pattern, a similar hazard ratio of 0.30, but also a better overall survival. But I should say that the number of patients is so small that we should be very careful to really make this as a kind of accomplished fact that the overall survival will be better. That's what we all think, hope maybe, but if you look soberly to the figures, we should be very careful. And then last year, you have the study of David Palma, the COMET study, and that was a study where also the PFS was better than the OS, but I should stress the study of David Palma was a randomized phase 2 trial, and was not mentioned to really have a better overall survival because it was a randomized phase 2 trial. It was also heterogeneous, where lung cancer was only part of, and lastly, it was metachronous disease. So that's very important to remember. INGAR and GOMEZ were synchronous metastasis induced. PALMA is metachronous disease. Next slide, please. And then you see here what I wanted to say. First of all, a look at the arrow. There's a lot of different histologies included amongst lung cancer, but also breast, colorectal, and very important also prostate cancer. And you see that there's a preponderance of prostate cancer patients, or an imbalance in the group having received SABR treatment. And the median time from diagnosis to the primary tumor to the random assignment was more than 2 years, just to stress that these are metachronous disease. And as you know, this is the phase 2 trial, but there's ongoing phase 3 trials, the SABR COMET 3 and 10, and that is to look at the possible gain of adding a local treatment to the best available systemic treatment, either in patients with up to 3 to 5 metastases and patients up to 10 metastases. And we'll see what comes out of the trials the coming years. Next slide, please. And if you look at the consensus meeting, for instance, of the ERTC, what is the definition of oligometastatic disease, both from the side of the number of metastatic sites and also the number of metastases in itself? Well, most people would agree it is up to 5 lesions. But the reason why we decided to have that as a definition is just because the inclusion criteria in the study mention up to 5 metastases. And that is mentioned in the left red column, that indeed in most studies it's allowed to have 3 to 5 metastases, either at the time of diagnosis or induced. In reality, however, and that's the right column, you see that the majority of the trials only included patients with up to 2, on average about 1.3 metastases. So there's a reluctance also for myself to enter patients with a lot of diffuse metastases in a protocol for radical treatment, and that's reality. So we should also think about that the data we have is based on patients with 1 or 2 metastases and hardly more. So also there, there's a, let's say, a conflict between what is said about the definition in theory and what is included in clinical trials. And I should also stress that in the ERTC definition, and that's mentioned in the study, if you read the full text, that this is a framework where we now have a definition to enter patients in trials. We're not saying that you should treat all patients with up to 5 metastases radically in clinical practice. Next slide, please. What is actually the problem of patients with oligometastatic disease? That is distant metastasis. This is just the more than 5-year follow-up of our trial, which we started already in 2006 or so. And what is the problem? That is that most patients, when they have a recurrence, they have a recurrence at non-irradiated or non-operated sites. So the biggest challenge of these patients is actually the systemic control. And that's why it's so important to give those patients the best available systemic treatment. And if you then look actually where the distant metastasis occurred, and that's not in our series, in a lot of those patients, patients still continue to recur in the same organ. And brain metastasis is a very good example of that. You can treat them very adequately, actually, but they continue to recur. So that's why it's so important to have the best available systemic treatment. And then, of course, if you have patients who live really long enough, so maybe after 3, 4, 5 years or so, then you do see second primary cancers occurring as well, which is logical. And so that means you should follow up those patients like you should follow up those patients with primary treated tumors as well. Next slide. So in conclusion, in patients with synchronous oligometastatic non-small cell lung cancer, the addition of a local treatment to systemic treatment probably improves PFS and possibly OS. I stress a local treatment because we don't have any argument that one local treatment is better than the other, as long as it's a radical treatment. I say also probably improves PFS because you have seen the trials, and that's not very strong evidence. And that's also why I say possibly OS. That's what we all hope and think and believe. But again, the data are scarce. Then local recurrences are rare. That's what I told you. And distant relapses are frequent. So improvement of systemic treatment is really needed. And that's actually why, in most cases, we select a patient according to the response to induction systemic treatment. And we do that actually to avoid over-treatment. And as mentioned already, because we had a question about that subject, treatment of brain metastasis first is frequently, but not always indicated. And so it's logical to start with the best systemic treatment, a targeted agent, chemo, IO, and so on. And most of the time, we continue also with the TKI and with the immuno treatment, with or without chemotherapy, because we know that in metastatic disease, that is the best option. And that's why we do it. But of course, the question still is, are there some patients with oligometastatic disease who received, say, 3 months of induction treatment followed by radical treatment and have a complete clinical remission? Maybe we can stop those systemic treatment, but that's an open research question, as is the question, of course, to continue during radiation TKI treatment. That depends also on the type of TKI, but in general, we continue with the immuno treatment, at least during radiation. And as I already told you, inclusion in studies is mandatory. Thank you.
Okay, thank you very much. I think we best go first to the comments and the slides Professor Huber has prepared, and then afterwards we can go back to the questions that are being asked in the questions bar. Professor Huber?
Yes. So these are my disclosures, and when we are speaking about oligometastatic disease, we have the clinical definitions you heard already, So a limited number of metastases in a limited number of organs. This is not directly mirrored in TNM, in the TNM system. In TNM8, we have M1A, intrathoracic spread, M1B, single extrathoracic metastasis, and then M1C is everything else. When we are looking at prognosis, M1A and B are very similar, with a median survival time of 11.5 months and a 5-year survival rate of 10%. M1C has a median survival rate of 6 months and a 5-year survival rate of 0. Next slide, please. Here you see it graphically, and when you are looking at the two lower curves, then it's clear there is a difference between intrathoracic spread and single extrathoracic spread and multiple metastases. Unfortunately, we don't have a large database regarding the clinical definition of oligometastatic disease. Next slide. Also from the ISLC database regarding lymph nodes in lung cancer, here you can also very clearly see that the prognosis is a lot determined by the amount of lymph node involvement. Next slide. And when we are looking at N2, also the levels, how many levels are involved, whether it's microscopic disease or already seeable on imaging, is relevant regarding prognosis. And you are looking at a difference of about 40% 5-year survival in microscopic 1 level, single level, versus below 10% if there is already lymph node involvement on several levels on imaging. Next slide. And also we know general rule, prognosis is determined by the performance status. And therefore, when we are speaking about oligometastatic disease and the radical treatment, we have also this to have in mind. Next slide. We are primarily speaking about the synchronous oligometastatic disease in this webinar. And oligometastatic disease is always a systemic disease, a metastatic disease. The prognosis is definitely varying. And at the time of presentation, the individual cause is usually not known. This is one of the reasons why we prefer to start with systemic therapy and then to better understand the cause, the individual cause of this disease. In a multimodality setting, mediastinal lymph node involvement and bone metastasis are rather surely unfavorable factors. Next slide. When we are looking at the data, as already mentioned several times, we have only few prospective unbiased data. And in these patients, if they are suitable, we should combine a local therapy, local ablative therapy with systemic therapy. When we are speaking about systemic therapy, we would like to apply the best available at the moment. So if we have a clear driver mutation situation, we would prefer targeted therapy. If we have no driver mutations at the moment, immunochemotherapy is usually the best way forwards. Of course, we know that the data which are there regarding oligometastatic disease are mostly made with chemotherapy, but we believe that the advantage of immunochemotherapy is that large that we should use this. Now, what are favorable factors? So not everyone with oligometastatic disease in my mind can be treated with a multimodality setting, but there are favorable factors which are speaking in favor of a multimodality treatment. It should be a fit patient, younger age is preferable, no relevant comorbidities, an adequate functional status, no mediastinal lymph node involvement, no bone metastasis, and ideally response to systemic therapy. Next. The functional treatability, if we are not in the driver mutation situation, please click all, is depending also on the comorbidity. And usually these patients have a smoking history and are older, and therefore they don't have only lung cancer, they have also several other limitations. Next. Regarding surgery, we have relatively clear data that cardiovascular and pulmonary function is the limiting factor usually. And there are guidelines from the EIS and ESTS from 2009, which are at the moment in an update process. But overall, you need an FEV1 and DLCO above 80, below 80. You should use an exercise testing to calculate the risk. Next slide. So I think it's still work in progress. We should offer these options to suitable patients, but we should do it at the best in clinical trials.
Okay, thank you, Professor Huber. Just going back to my screen here. We prepared another case, but I think it's more important to answer to the questions of the audience. And I think we already had a few very interesting questions to answer. So let's go first to where we ended. There's a question, would you insist on mediastinal staging prior to surgery? And how would you do it? Would you go for EBUS or mediastinoscopy? Maybe I directly put this question to Professor Opitz.
Yeah, I think it's a very good question, and there were a number of questions regarding the mediastinal staging here from the audience. When we looked at our own data, and this has been confirmed in many other retrospective cohorts and prospective cohorts, that mediastinal lymph node involvement is indeed a bad prognostic factor, which would be an absolute pro for a mediastinal invasive staging before surgery is performed. And it can be, according to local practice, either EBUS or mediastinoscopy. EBUS obviously has the advantage of being less invasive. And if you consider to do re-staging, also better than having done an EBUS before and then a mediastinoscopy at first hand. It is, funny enough, not part of the CHESS protocol, though. If it's PET negative and no enlarged CT scan lymph nodes, you are not obliged to do mediastinal staging. But I think if you are treating these patients off a trial protocol, I would highly recommend to perform a staging in the mediastinum.
Okay, and what about restaging? I don't know if Professor de Ruysscher can comment on this.
Well, first of all, I should say I agree with Isabel, and also that is true for the non-surgical patients, because also in the non-surgical patients, the fact that you have metastatic lymph nodes is also a bad prognostic sign, A, and B, it can also help you to delineate much better the radiation volumes as well. So I think in these radical patients, you should stage them according to the best local practice, and that can be also mediastinoscopy and certainly EBUS. Restaging is also important because there's has been said mediastinal lymph node involvement is a bad prognostic factor, but on the other hand, if you have patients who have a very favorable response, and best is actually to confirm the response in the mediastinum, those patients, even though they may in the beginning have N2 disease, they may still have a beneficial effect of a radical local treatment, whatever the radical local treatment is. So I think that restaging certainly in these patients is really worthwhile. Yes.
And in particular, if I can add, in the context of immunotherapy, that we want to exclude pseudoprogression, because this can make a positive mediastinum, and then you are misled, and this is indeed an additional argument for restaging.
I think you need a mediastinal staging also to discuss it properly with the patient, whether he wants more aggressive therapy or not. So regarding prognosis, it's absolutely important. It's also important to know the response if there was mediastinal involvement before treatment. And I usually would do EBUS first, and only in doubt mediastinoscopy.
Okay, that's clear. So on the question mediastinal staging, the answer is yes in all cases actually, and then according to the local protocol. But if you can do EBUS, maybe that's the least invasive indeed. That's a very specific question here. What can you say if the recipient after a lung transplantation has developed a donor-associated colorectal lung metastasis? This is also oligometastatic disease, of course, but I'm not sure if anyone of you has any experience with this.
Yeah, maybe I can comment on this. I mean, it's not oligometastatic lung cancer, of course, but it's a difficult situation. I appreciate that, but if it's a single metastasis, I would go for a resection if functionally tolerated for such a case.
And any systemic treatment? Depending
on the whole staging, so like PET-CT restaging, then I'm not a colorectal cancer specialist. Maybe Dirk and Huber want to comment on this.
Well, regarding solitary lung metastasis in colon cancer, if the time interval is long enough, primarily resection would be the treatment of choice. I would have also the problem in this situation with transplantation that all our systemic treatments are interfering with the immunosuppression which is needed for transplantation. So probably I would only resect and do a very close follow-up.
Mm-hmm. And the realistic alternative in these patients is also stereotactic radiation if it's a nodule amendable for that, and if you're sure about the diagnosis, which is also not trivial in those patients, of course, if you see an FDG avid lesion. So that would be my first point. You should really confirm that it's metastatic disease, and if it's done, then you have the possibility to resect or to irradiate with stereotactic techniques. But I would also say support what Rudolf is saying, that is that it should be viewed in the context of the immune suppression of those patients as well, of course.
Mm-hmm. Okay, then another interesting question is the following: in case of solitary tumors on either side, how do you decide if it's metastatic or synchronous primary? Do you always insist of a bilateral histology? I think this was indeed a question in the first case we discussed. Two sides, tumor on two sides. Is it metastatic or not? So how do you handle this? Maybe I start with Professor Ruysscher.
Well, we try to obtain, like everybody, I think of us, to obtain pathology. And we are quite liberal in transthoracic punctures as well. And we are doing for many years LOH analysis and now also deep LOH analysis in order to see whether there's a genetic relation between one tumor and another tumor. And sometimes, and it's not only to see whether it's a metastasis of one the mother tumor to the other lung, for instance, which you will, by the way, treat radically anyway if you have the possibility. But sometimes the reality is that those patients also had some other primary tumor in their history. For most of them, of course, had a neck cancer, and then you have a squamous cell cancer, and you don't know what was the primary, and that's also an argument to go for a deep genetic analysis in many cases. Having said that, sometimes it's not possible to have this type of histology, and then you have a discussion, and also to see would it make a therapeutic difference, of course, because you should not harm the patient as well in histology.
I also would like to get histology from each nodule or mass. The same reasons which Dirk already told. And there are some patients where you have, for example, in one lesion an EGFR mutation, in the other not. So this would also have consequences for the treatment.
Okay. Any other comments? Yeah. Okay. You agree, Professor Opitz. Then a question on circulating tumor cells. Would that help the decision-making in selection of oligometastatic patients? Professor Huber?
It may be. We don't have the data. We are now getting data regarding minimal residual disease. So it may be that the amount is relevant, but at the moment I can't give you an answer.
Well, I think that there's a lot of future in there, and I'm sure that when the standardization is better and certainly also the sensitivity is increasing, that will be probably part of the evaluation process, and maybe the prognostication, maybe in who will tell 4, 5, 6 years or so. But outside of the clinical trial, and also in view that we don't have standardization as far as I know, I wouldn't recommend it.
Yeah, I also agree. I think we haven't the right assay to go yet at this stage. And there are other trials ongoing, like, for example, the MERMAID trial, which is assessing MDR in an adjuvant treatment allocation protocol, and other trials going on. But at this stage, maybe as a translational endpoint in a trial, but not as a factor for treatment allocation. I think we're not yet there.
Okay, then I skip some questions because we already answered them. What's the expert opinion about using local control by surgical resection first, followed by adjuvant systemic therapy? I think most of you already answered on that, and especially Professor Huber saying first systemic treatment, and now we can see how the disease is actually evolving. I don't know if you want to comment on this.
Well, I would stay with this remark or this statement, but of course there are situations where local treatment may be the best option as first option. So, for example, if you have a cavernous tumor where you have problems with systemic therapy, then it would be better to operate primarily on it and then give adjuvant systemic therapy.
Okay. Then some questions on pneumonectomy. I'll translate it in, is this a bridge too far or not?
I think that's a very good question, and maybe talk about pneumonectomy later. In principle, what we have to say and may not have stressed enough so far, I think it's very important in whatever local LAT you are assigning to the patient, it should be well balanced with the expected toxicity, being either complications from surgery, but the same, and Dirk might comment on this also for radiotherapy. I think it should be discussed interdisciplinarily together with the patient, also about the expected consequences for his quality of life. And here we come to the situation of pneumonectomy. I think it's important to openly discuss what would be his quality of life expectations if you take a whole lung for somebody who might eventually only have a few months left to live. I think that's, from my perspective, I would not go for a pneumonectomy, only in very exceptional cases.
Yeah, I agree with that, but and the same is also true for the radiation to very high doses, to very big volumes, where you can also estimate the probability of severe and also chronic complications that should also be avoided, because like Isabel said, first of all, many of those patients who need such a big surgery or such a big radiation have intrinsically a bad prognosis, so that goes sometimes hand in hand. And on the other hand, you should also know that there's a lot of uncertainty, because nowadays in the era of TKIs and the immuno or immunochemo, many of those patients will have a prolonged, very good overall survival or life with disease, but in a very good quality. And you could really ruin this by adding an aggressive local treatment, whatever the local treatment may be. And that's something we have to realize very well and to discuss with the patient what the limitations are.
Mm-hmm.
Maybe just one point I would like to add is, I mean, if you are embarking in such an operation, the most important is you have to achieve R0 resection. I mean, that's the minimum requirement that we need. And if you have to go until pneumonectomy, it might be already a sign that it's really advanced disease, as Dirk was saying. And I don't exclude that there might be situations where it's a solution, but if you do it, the absolute goal should be an R0 resection.
And again, if you are doing systemic therapy before and you can't downstage the tumor to a better resectable situation, then you don't have a long-term prognosis.
Mm-hmm. So then we come to maybe the last question. Do you then exclude in 2 patients at the initial diagnosis, because there you already have an, let's say, bad prognosis, or do you wait after your systemic induction therapy for the response?
In the protocol, for example, single station and 2 even other stations are allowed in the chest protocol. And even if after restaging there is a single N2, which will be resected, they are included for aggressive local ablative therapy to the primary tumor.
Exactly, it's like Rudolf was saying, that is, if you have a very good response of the systemic treatment, then those patients can be treated radically, even though they had in the beginning N2 or even N3 disease. It all depends on the systemic treatment. And of course, if you then, in that situation, can give, for instance, in multi-level N2 or N3 disease, also a reasonable radiation toxicity as well. That is the same as what we just discussed with pneumonectomy.
Okay. You see, time goes fast when you're having fun. It's already an hour later. I think we're just going to wrap up a little bit. Next case can be for some extra webinar maybe, but okay, people might have some other things to do. Today was a great webinar for me, and I hope for all of you. We had more than 200 people watching live, which is really spectacular. Maybe some take-home messages on oligometastatic lung disease. Oligometastatic lung disease is a metastatic disease, so we really need this systemic treatment as a basic step. Scientific evidence is scarce. We should always, that's also something I remember from today, we should always help our patients. So also in times, not only in time and in terms of survival, but also in quality of life. So we should discuss this with our patient. Patient treatment should actually be done in clinical trials for now, because the evidence is indeed scarce. The least toxic local treatment should be administered in each location, and this can indeed be radiotherapy as well as surgical therapy. Patient selection is of utmost importance, and we need to discuss all these patients in a multidisciplinary board. I would like to thank you, my guest panel of experts on behalf of the ESTS Learning Affairs Committee. So Professor Opitz, Professor de Ruysscher, and Professor Huber. And I hope to see all of you next month on the Oncology Update for Surgeons webinar with Johan van Steenkiste. Thank you, and see you next time.